Okay, sir. Good evening and welcome to one and all. Myself, Rupsha from Clarnet, the designated session assistant for a seamless experience of the session. Clarnet is very proud to be a digital partner of this event organized by Society of Onco-Anesthesia Perioperative Care, and the topic of today's session is Lecture Series 25. Clarnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. So let's begin today's session, for which I would like to invite Dr. Rakesh Garg, sir. Over to you, sir. Kindly proceed with your talk.
Thank you so much, Rupsa and the Clarnet, for helping us to take this webinar series. In today's webinar series, after many of the interactive sessions we have from the experts, today we are moving to a different type of seminar which will be good for our understanding, and it is the journal club. So there are a lot of evidences which are generated through various research and they are published, but we need to understand that how to interpret those published literature to bring some change into the clinical practice. It's just not the articles which are published and the conclusion which is there at the end and change our clinical practice, but it requires a lot more understanding how this can be implicated if required for a change into clinical practice. And for that, today's session is important. Equally important will be the topic today. So I will request chairperson for that today, Dr. Vibhavari Naik and Dr. Indira Gurajala, who will be chairing the session today. Both personalities are international personalities. Everybody knows them very well. Madam Naik is senior consultant at Basavaratam Indo-American Cancer Hospital and Research Institute, Hyderabad. I know her personally, and she is one of the excellent researcher, clinician, academician, in addition to a wonderful person with a lot of accolades to her credit from all angles. So welcome, madam. And we also have Dr. Indira Gurajala with us, who is also a senior person with a lot of experience into the clinics, academics, and research. She is professor at Nizam's Hyderabad. She has again many accolades with regards to her contribution towards the academic through publications, through conferences, through bringing out various research and organizational aspect. And both of chairpersons are very well suited for today's topic as they have vast experience in taking care of patients for cancer surgeries. Over to you, madams.
Thank you. Thank you, Dr. Rakesh. It is indeed my pleasure to be here again today, chairing yet another session for SOAPC Academics. And as all of you know, SOAPC has been doing an excellent work in promoting academics, conducting these sessions regularly. And this time it is going to be Journal Club. Dr. Rakesh has already explained why journal clubs are important. And just to add my two pennies, I feel it is important not just to abreast ourselves with the current scientific literature, which can be translated to our patient management, but also it is important for fellows, the young researchers, so that we can learn a little more about the research methodology, newer statistical methods, and also understand how to write a journal article well. For today's session, we have selected a randomized control trial that has been published recently in BJA. And this is about perioperative analgesic management in patients undergoing hepatectomies. And the reason we chose this because I'm sure you'll agree that managing analgesia perioperatively for hepatectomy patients is definitely challenging. We have some limitations in the use of regional anesthesia, particularly epidural, and hence we have to rely on multimodal analgesia. This article, particularly the authors, have used intravenous lignocaine as an infusion over 3 days, and they have used it in a different way. And we thought it would be interesting to share this for today's journal club. Dr. Rakesh has already introduced Dr. Indira, who is a dear friend of mine and would be co-chairing this session. And also I want to introduce Dr. Taseen Mahvish, who's recently finished her fellowship in onco-anesthesia and pain medicine at Basavatarakam Indo-American Cancer Hospital and Research Institute. And now she has joined us as a consultant. So over to you, Dr. Taseen, with your journal club.
Respected chairpersons, organizing committee members, and seniors, wish you a warm good evening. Thank you, ma'am, for the kind introduction. I'm grateful to the organizing committee of SOPSI for giving me such a wonderful opportunity to present a journal club. I'll quickly start my presentation. So today's topic is journal club. I'll be discussing the journal under the following headings. So the title of our topic is Efficacy of Prolonged Intravenous Lidocaine Infusion for Postoperative Movement Evoked Pain Following Hepatectomy, a double-blinded randomized placebo-controlled trial. This study was conducted at West China Hospital, Sichuan University of China, and it was published in British Journal of Anesthesia. They have received this article on 8th November 2022 and accepted on 11th March 2023. And it was published online on 16th May 2023 in the British Journal of Anesthesia, published by Elsevier Limited. About the journal, British Journal of Anesthesia, as we know, this is the oldest and the largest independent journal, which publishes the original work in anesthesia, critical care, and pain perioperative medicine. It has got a very good impact factor of 9.8, and it is a subscription-based journal. Critical appraisal, it is a peer-reviewed, it is paid journal, few are open access, and it inclusion in major indexing sites such as PubMed and Google Scholar. So we'll be discussing today's topic of this article, and by using the Concert 2010 checklist. They have given a 25 items checklist for each subheading. The other guidelines we have used is Center for Evidence-Based Medicine. They have also given a similar kind of guidelines. And one more guideline is Critical Appraisal Skills Program. So this was originally based on JAMA users guideline, and they have also considered the use of Concert 2010 guideline, and this one is an updated version. Title: Efficacy of Prolonged Intravenous Lidocaine Infusion for Postoperative Movement Evoked Pain Following Hepatectomy, a double-blinded randomized placebo-controlled trial. Critical Appraisal: Identification as a randomized trial in the title. Yes, they have mentioned. So our title critical appraisal is, title is complete, it makes sense, it has aims and objectives, and it indicates the research question. Abstract. Background. The analgesic effect of intravenous lidocaine varies with the duration of lidocaine infusion and surgery type. So they have tested the hypothesis stating that prolonged lidocaine infusion elevates postoperative pain in patients recovering from hepatectomy over the first 3 postoperative days. Methodology. They have selected patients undergoing elective hepatectomy, and they were randomly assigned to receive prolonged IV lidocaine treatment or placebo, the primary outcome being incidence of moderate to severe movement evoked pain at 24 hours postoperatively, and the secondary outcome being incidence of moderate to severe pain during movement and at rest throughout the first 3 postoperative days. They have also included postoperative opioid consumption and pulmonary complication. They have monitored the lidocaine concentration levels. The results, they have enrolled 260 subjects, and the intravenous lidocaine infusion lowered the incidence of moderate to severe movement evoked pain at 24 and 48 hours postoperatively and reduced the pain scores with a 95% confidence interval, and morphine equivalent consumption was mentioned. Median lidocaine in concentration were 1.5, 1.9 and 1.1 microgram per ml. Lidocaine also reduced the incidence of postoperative pulmonary complications. So they have concluded this study in the abstract, stating that prolonged intravenous lidocaine infusion reduced the incidence of moderate to severe movement evoked pain for 48 hours postoperatively after hepatectomy. However, the reduction in pain scores and opioid consumption by lidocaine was below minimal clinically important difference. They have also mentioned their clinical trial registration number. So the concert guidelines for abstract, they have given a separate checklist. So we'll be checking this abstract by using this checklist. Title, identification of the study as randomized, yes. Authors, contact details for the corresponding author, it is given. Trial design, description of the trial design is parallel. Participants, eligibility criteria for participants and settings where the data were collected, it is not mentioned. They have just mentioned that they have included patients undergoing hepatectomy. Interventions, interventions intended for each group, it is given. Objective, specific objective or hypothesis, yes, it is given. Outcome, clearly defined primary outcome for this report, yes. Randomization, how patients were allocated to interventions, that was given. Blinding, whether or not participants, caregivers and assessors, they were blinded, yes. Numbers randomized, number of participants randomized to each group, it was not mentioned. They have just mentioned that 260 members were enrolled. Recruitment, trial status, it is completed. Numbers analyzed, number of participants analyzed in each group. As I said earlier, it is not mentioned. Outcome, for the primary outcome, a result for each group and the estimated effect size and its precision, it is given. Harms, important adverse effects or side effects, they have not mentioned in the abstract. Conclusion, general interpretation of the results, it is given but incomplete with respect to hypothesis. Trial registration, registration number and name of the trial register, it is mentioned. And funding, it is not mentioned in the abstract. So abstract critical appraisal, this abstract according to us, it is structured, it is informative, summarizes the article, it matches the detailed text in the article. NRS used to quantify pain, it was not mentioned. And when the lidocaine infusion was started, it is not clear. And abstract conclusion does not reciprocate its hypothesis completely, because in conclusion they have mentioned about the pain scores for 24 and 48 hours, whereas in the hypothesis they have mentioned about 72 hours. Over to you.
Yeah, thank you, Tasveen. I thank Dr. Rakesh Garg for the kind invitation and introduction, and also Dr. Vibha for inviting me to co-chair this session. And coming to this particular article, when Vibha said that she would like to do this article, I was interested because I thought the subject was very topical and relevant, with so much research going on about Lignocaine and its beneficial effects in cancer patients. So when we are looking at an abstract, what normally we do is see whether it is giving information and the essence of the article without too much details, but at the same time, whether it is providing adequate information to generate interest in the reader to read the entire article. So this particular journal article studying the effects of lidocaine infusion for 72 hours in post-hepatectomy patients, the title, as far as the title is concerned, it is good. But the abstract, though the abstract is not supposed to give you every minute aspect, I found it a little vague and non-detailed, in fact. So I agree with Tasveen that a lot of details regarding the methodology, which would have been important to be mentioned in abstract, are missing, like the trial design. Of course, it is mentioned as randomized control trial in the title, but it is nowhere mentioned in the methodology, nor how the infusion is given, the demographics, which patients are included, whether they are adults, and whether it was an open hepatectomy. All these details which are important are not there in the methodology. And even in the results, we usually say so many enrolled, randomized, and analyzed. They just give that 260 patients were enrolled. And there is no mention of any patient having adverse events, like 260 patients, even if you assume, because they haven't given any number in the Lignocaine group, even if you assume 100 patients were randomized to Lignocaine group, not one had adverse events. And when you look at the concentrations given in the abstract, they are, in the lower range of therapeutic levels. So I was wondering that you give an infusion of lidocaine for 3 days and you've taken half the liver, but still the concentrations are so low. So it is as much as the details which were given as the details which were not given, which provoked interest in me to read the article further.
Sure. Thank you, Dr. Indira. Yeah. Thank you, Taseen, for starting it in a very structured way. and introducing the checklists that need to be used for the journal clubs. As Dr. Indira said, even I felt that we all know that abstract has limited words, and we would really like to have as much information as possible in abstract. The most important reason for this is that for journals that are paid access, for most of the world, what is available is just the abstract. So abstract should have the right message sent across. One thing I just wanted to say that they've mentioned morphine equivalence. However, they haven't mentioned whether it's oral or intravenous, though most of the times it is considered to be oral, but the conversion is also there in intravenous. So I think it can cause a little bit of confusion because they have not explicitly mentioned it. Another thing I wanted to point upon is the harms. Like Dr. Indira said, actually, I think 2 patients in the Lignocaine group did have symptoms of toxicity, and it is not mentioned in the abstract. It is important that harms are mentioned in the abstract because, as I said, that only abstract may be available for most of us to read. And whenever they introduce a therapy, a novel therapy, it is also very pertinent that the harms are included in the abstract. That's the reason why it has been included in the consort abstract guidelines. I think for the rest of it, I just had a question for Taseen. Taseen, did you realize that there are 2 corresponding authors for this article?
Yes,
Is this the norm?
actually, the norm is only one corresponding author, but it depends upon the journal when they want more than one article, one corresponding author to be there. So it depends upon the journal. They have to contact with those members. And
I'm going to ask a quick question to Dr. Rakesh here. Dr. Rakesh, yeah. So what are your thoughts on having 2 corresponding authors? I know that Indian Journal has only one corresponding author, the IJA.
So usually it is, if you put it, why do we want a corresponding author is basically, it does not have seniority or juniority or something. It is just that a single person is taking a responsibility of coordinating with all the authors during the various process, and the post print, if there is some issue, they can be contacted. But all the authors details are there in the system, which editor-in-chief can look for when it is being submitted. So sometimes it happens that the main correspondence is being done by 2 category of people, because if you see some of the articles, there will be a statistician involved, or there will be a person who is non-speciality, or there may be something from the secretariat staff. So that's why some of the journals will wish to have them, but it's not the standard practice, but depends upon the journal requirement.
Sure. Thank you. Thank you so much. Okay, then I think we can move on. Do you have any comments so far, Dr. Rakesh? I'm going to rope you in as a chairperson, co-moderator now.
Doing perfectly fine. All
sure.
good.
Yeah. Dr. Taseen, could we move ahead?
Introduction. The first line therapy for pain management after upper abdominal surgeries is thoracic epidural analgesia, which has demonstrated superior pain relief for movement evoked pain. Because these hepatectomy patients, they develop coagulopathy at any point of time. So opioid administration through PCI pumps paired with the peripheral nerve blocks, subcutaneous wound infiltrations, they serve as a mainstay of postoperative analgesia. The intravenous lidocaine has been proposed as an attractive adjunct because of its properties like anti-nociception, anti-hyperalgesia, and anti-inflammatory properties. So the research question proposed by them was prolonged IV lidocaine infusion would elevate postoperative pain, especially movement-evoked pain, over the first 3 postoperative days in this population. Critical appraisal. The scientific background and explanation of rationale, yes, it is given clearly. Specific objectives or hypothesis, it is mentioned. So the introduction is structured. They have presented the introduction in 3 parts: opening, body, and termination. They have built on existing literature. All citations are well followed. Introduction has presented the need of the study and has mentioned the research question and hypothesis. So the question comes whether this study is relevant or not. Then I would say yes, absolutely, because there were always challenges in planning the analgesia of post-hepatectomy patients.
Sure. I think we'll just pause here, Taseen. I think they've built up the introduction, the background to the topic really well, and they have explicitly mentioned the research question also. I don't think I have anything else to comment on this part. Dr. Indira, do you have anything to add?
Yeah, so this in the introduction, when you're actually giving a drug, we are not only concerned with the pharmacodynamics, but also with the pharmacokinetics. And lignocaine infusion being given for a breast or a colorectal is different from lignocaine infusion being in a hepatic surgery. So in the introduction, probably I feel that there should have been some research done regarding the safety of this in patients undergoing hepatectomy particularly. And so that both the pharmacodynamic and kinetic aspect of running an infusion in this substrate of population are properly researched, and the research questions are framed, including the drawbacks of or the negative effects of the drug which is being given.
Sure, I agree. Actually, there are some articles where intravenous lignocaine has been used in hepatectomy patients. However, this is the only study where it is being used for 3 post-operative days. So intraoperative use, yes, there is some literature. Up to first 24 hours, there is literature. So like Dr. Indira said, I think it would have been a good idea to quote that lignocaine has been used in post-hepatectomy patients in the early post-operative period. However, it has not been studied up to 72 hours. So yeah, I think that is a very important point she's added. Anything, Dr. Rakesh, from you?
Just a small point. So when you do a critical appraisal of a published paper, critical appraisal is for self, it's not for other. So say you are working at Indo-American, so this critical appraisal is for you. It is not for people at AIMS or people at SGPGI or people at down south or at other place. So when we say critical appraisal, you have one point you mentioned in the last wording that it was a concern to you. You said it was relevant. So when we say the relevancy has to be into the person who is doing a critical appraisal for that paper. So you need to mention it, that whether are you going for these type of surgical procedures, is the complication reported is similar to your complication, are you still noting for something? Say for example, if I put it this way, people will say that after thoracotomy there is a lot of pain, and in my clinical practice I'm using a lot of intrathecal morphine, and all my patients are absolutely fine for first 24 hours with the satisfaction score of almost 100%, with VAS of less than 3, with no rescue analgesia in first 24 hours. So this is if somebody says in the introduction that post-thoracotomy pain is a major challenge, it is not for me. I'm also always happy. I'm not facing any issues. So that paper is not suitable for me. So this is not relevant for me, for my center, for my patients. So when we say critical appraisal, you mentioned that this paper is to be used by whom, at what center. And that's why you need to have your data, that are you really facing challenge where you want to use this agent for your patients? If yes, then it can be done. So this is for people, everybody who's listening to us, that don't ask a people from Indo-American Institute or AIMS or somebody or Nizams that do a critical appraisal and let me know whether I can use this paper or not. Do it yourself, and that's why today's lecture is there. Over to you, ma'am.
Sure, thank you. Yeah, so let's move on, Dr. Taseen.
Research methods. So this data is a single institution study, and this study was conducted at University of Sichuan, China, and study population was patients undergoing hepatectomy. Study duration February 2022, October 2021, and the study design is double-blinded, randomized, placebo-controlled study, and they have mentioned the clinical trial registry number 2. Patient recruitment, inclusion criteria being patients included from age of 18 to 80 years with the ASA physical status of 1 to 3 scheduled for elective hepatectomies. Exclusion criteria being body weight less than 40 or more than 100 kg, metastasis in other organs, severe liver disease, renal impairment, cardiac rhythm disorders or systolic heart failure, allergy to any other drugs, chronic opioid use, and inability to comprehend NRS. Randomization and allocation. They have done by computer-generated method and allocation in the ratio of 1:1, and concealment was achieved by sealed opaque sequentially numbered envelopes. They have prepared a 20 ml syringe containing lidocaine solution of 1% at the rate of 1.5 mg per kg, or an equal amount of saline was used as bolus injection. Meanwhile, a 50 ml syringe containing either lidocaine 1%, same as 1.5 mg per kg, or saline was used for continuous infusion. An independent anesthesiologist was responsible for drawing bloods to monitor the lidocaine concentration. And one day before surgery, subjects were instructed on how to use PCI pump and how to rate their pain intensity. Study intervention. Lidocaine group subjects were administered an IV bolus of 1.5 mg per kg of lidocaine at induction with continuous infusion at 1.5 mg per kg per hour until the end of the surgery. And the PCA pump, interestingly, they have combined three different drugs, that is lidocaine 30 mg per kg, sufentanil 2 microgram per kg, and granisetron 12 mg, diluted to 200 ml in a normal saline to use for first 72 hours. Placebo group, they have received equivalent of volumes of saline. The postoperative PCA pump contained again sufentanil of 2 microgram per kg, granisetron to a total volume of 200 ml, and the background infusion rate was 2 ml, and the bolus volume was 2 ml, and the lockout interval was 15 minutes. Anesthetic management. Standardized anesthetic technique was used, and all patients were extubated in OR and transferred to PSU. And they have assessed their NRS for every 10 minutes, and subjects scoring more than 3. They were treated with sufentanil of 0.1 microgram per kg every 30 minutes. And once they have reached Aldrich score of 9, they have shifted to ward, and they have received the continuous infusion for first 72 hours. For the subjects whose NRS score was more than 3, the maximum dosage of 10 ml per hour were administered Dizocin 5 mg IV. Dizocin is an opioid agonist antagonist. It is similar to pentazocin, but it is not same. It is popularly used in China as popular opioid drug used in China. Study outcome. Primary outcome was the incidence of moderate to severe movement evoked pain at 24 hours post-operatively. Secondary outcome. Incidence of moderate to severe movement evoked pain at 48 and 72 hours. Incidence of moderate to severe pain at rest at 3 time intervals. Cumulative opioid consumption at 3 time intervals. Time to recovery of bowel function, incidence of PONV during first 72 hours, incidence of postoperative pulmonary complications, length of hospital stay, and satisfaction score by using the 11-point Likert scale. This is the study protocol they have submitted to the clinical trial registry, where the highlighted point is the blood sample was collected. They wanted to collect for measurement of IL-6 and tumor necrosis factor alpha. And in the secondary outcomes also, they have mentioned the same. But in the published article, they have not mentioned about this inflammatory markers. This is their study protocol published before the main article. Statistical analysis. It was performed by using a modified intention to treat approach. Modified intention to treat approach is this one of the method for analysis, where all the subjects need to be exposed to the study intervention at least once. The data were tested for normality by histograms and Shapiro-Wilk test. The mean and standard deviations were used for descriptive analysis, and the median interquartile range were used for non-normally distributed data. Baseline balance was assessed with the absolute standardized difference of more than or equal to 0.234 were considered significant. They have used 95% of confidence interval. Additional tests used were sample t-test and Mann-Whitney U-test for normally and non-normally distributed data respectively. Categorical variables were compared with the chi-square test or Fisher exact test, with a p-value of less than 0.05 was considered statistically significant. And they have used the SPSS version of 22. Sample size, they have calculated their sample size by using their previous pilot study, where they have included 76 patients who had elective hepatectomy, where 49% patients experienced moderate to severe pain at 24 hours postoperatively in the Lidocaine group, compared with the placebo group was 67%. Based upon these findings, they have calculated the sample size by using the two independent proportion test by in PASS version 15 with an alpha value of 0.05 detail and a beta value of 0.2 with an additional drop rate of 10% coming to the total sample size of 130 in each group. Critical appraisal methodology. Trial design. Description of trial design including allocation ratio. It is a parallel trial and a allocation ratio of 1:1. Important changes to the methods after trial commencement. It is not mentioned like IL-6 and tumor necrosis factor alpha, which was not mentioned. Participants, eligibility criteria for participants, yes, it is given. Settings and locations where the data were collected, it is mentioned. Interventions for each group with sufficient details to allow replication, including how and when they are actually administered, yes, it is clear. Outcomes, completely defined pre-specified primary and secondary outcome measures, including how and when they were assessed, yes. Any changes to trial outcomes after the trial commenced with reason, yes. But reason is not given why they have excluded the inflammatory markers in the main study. Sample size, how sample size was determined? They have determined by using their pilot study. When applicable, explanation of any interim analysis and stopping guidelines. No interim analysis was done. Randomization, sequence generation, methods used to generate random allocation sequence. It was computer generated. Type of randomization used was simple randomization. Allocation concealment mechanism. Mechanism used to implement the random allocation sequence, describing any steps taken to conceal the sequence until the interventions were assigned. Yes, it was clearly mentioned. Implementation, who generated random allocation sequence, who enrolled participants, who assigned participants to interventions, computer-based and separate anesthetist for each task. Blinding, if done, who was blinded after assignment to interventions? Participant and the care providers were blinded. If relevant, description of the similarity of interventions. They tried to maintain blinding for blood drawing, that is sham handle. Sham handle means in the placebo group, they have not actually drawn the sample, but to keep the blinding to care provider, they have enacted as if they have taken the sample. Statistical methods. Statistical method used to compare groups for primary and the secondary outcome were chi-square test and the Fisher test. Methods for additional analysis such as subgroup analysis and adjusted analysis was Mann-Whitney U-test and T-test. Critical appraisal. Combining 3 different drugs in a PCA could have affected the efficacy and pH. So this was not mentioned by the authors. Opioid added in the PCA pump can be a confounding factor. The study design of the research could have been more appropriate if they have used alone lidocaine versus placebo. The sample size is representative of the population of interest. The methods used were appropriate and explained in detail. Triple blinding could have been used, and there is a disparity in the protocol submitted and the published article. Though wound infiltration was used, some sort of regional anesthesia technique could have been used. Statistical analysis were done by using a absolute standardized difference instead of p-values, which is an alternative method to do the statistical analysis.
Thank you, Tasvi. So coming to the methods, I have a lot of issues with the methods. So inclusion criteria. So when you actually talk about hepatectomy, you would like to know what kind of hepatectomy it is and how much will be the remnant tissue which is left. Because our lidocaine is metabolized mainly in the liver. and also whether the primary pathology is for, what is the primary pathology. Now, in the protocol, actually, they have given that most of the patients were undergoing hepatectomy for primary liver cancer. So that has not been mentioned anywhere in the actual main study. And also they've included both laparoscopic and open hepatectomies, which probably have different pain. They cause different amounts of pain. And after inclusion, there has been no exclusion criteria. I mean, if I was doing this study, or if I would definitely have post-inclusion exclusion criteria, such as mechanical ventilation. And they've done 260 patients included in the study, and not one went on to ventilator. I really have to appreciate their anesthetic and surgical management. But I would definitely include mechanical ventilation as an exclusion criteria. And also with the potential for bleeding during hepatectomy, and the requirement for resuscitation with fluids and drugs, which can, the hypotension and all these hemodynamic derangements themselves can actually cause problems in lidocaine metabolism. So including hemodynamic instability probably would also be an exclusion criteria. They have said that they have excluded patients who have had cardiovascular events which did not respond to symptomatic treatment, but I would like to have a more defined criteria. Now, coming to the infusions, if you actually break down, it is coming to 0.3 milligram per kg per hour, the lignocaine dose, and the sufentanil dose as 0.02 mics per kg per hour. So even if the patient is, giving all the 4 top-up doses, the max dose of lignocaine would be 1.5, and the sufentanil will be 0.1 mic, which is way below what is usually used as an infusion. And so therein, I feel that the doses were very low. And also, I would, as Taseen said, give the lignocaine separately and have a constant lignocaine infusion. I think these the investigators have actually chosen to have a patient demand lignocaine concentration, because maybe because of the safety. But then I would actually prefer to have a continuous infusion. And NRS monitoring, they said every 10 minutes, but that I think is in PACU. How often they used to do, imagine waking up the patient who's sleeping every 10 minutes and asking them, are you okay? Take a deep breath. So that is not very much mentioned in the methodology. And monitoring for adverse effects. Now, they have monitored the lidocaine concentrations, but as we know, the metabolites of lidocaine themselves have a potential for toxicity. So lidocaine is metabolized further into glycine xylidate and monoethyl glycine xylidate. So they also contribute to the toxicity. So I think those also should have been included in the analysis for the toxicity. And the second thing is the methodology. What I really found interesting was the methodology. And they have used the intention to treat analysis. This is in this kind of analysis, all the patients who've been randomized will undergo analysis. What we usually do is per protocol analysis, where only the patients in whom we have followed the protocol verbatim are included. So when you're actually doing a drug trial in which you want to prove one drug is superior to another, apparently the ITT analysis is better than the per protocol analysis. So this was something which I found interesting. And the second thing was use of this absolute standardized difference instead of the p-values. And from what I understand is that when you use this absolute standardized difference, what they do is they divide the mean difference between the two groups, and with a pooled standard deviation, or sometimes the standard deviation of the control. And this is supposed to remove the confounding variables in the baseline characteristics of the study. So that way, the treatment effect is not because of the baseline variability in the baseline characteristics. So these two things I found was different in this particular study. And if you see the results, you will understand how these different statistical methods have been expressed in the results.
Sure. Yeah, sure. Thank you. Before I start, I just wanted to ask Dr. Rakesh, is it okay to pull out the trial registry, because the trial registry number is given, to pull out the trial registry number and look into what was planned at that time and then compare like we have done? Is it okay to do it like that?
Yeah, absolutely. At times, because of the reporting requirement, there could be some adverse drug reaction, and they could inform you to stop the study in between or do something, because trial registration has been done before the process of starting a study. So because of the adverse drug reaction committees, sometimes they can stop some studies and say this is done, number one. Number two, sometimes in some of the big studies, when they are doing some intervention which can have beneficial effect, which is in one group, which is unexpected, they were not hypothesized earlier. So even in certain studies, they say that the study has been prematurely stopped because there was obvious benefit of one group of the other, and for ethical reasons, the other group may not be denied, and hence it was studied and concluded that group A is better than group B. So we need to understand this nitty-gritty, and that's why if we have a trial registration, we could concur from the present study, and majority of research, they will disclose it, that those a participation of the sample size was 100, but we stopped at 50 because there was increased death rate, mortality, morbidity, or there was obvious benefit. So that's why this needs to be done. And simultaneously, sometimes when revision is being done, sometimes there will be major changes. So those changes is usually screened at the level of before publication, should not happen, but sometimes it can be missed. So when we are doing critical appraisal, ensure that what was proposed has been reported now into the study. So that's why this is important for our understanding.
Sure, thank you. So I think one of the most important thing that has been missed, which was there in the trial protocol and has not been mentioned, is the measurement of inflammatory markers. And we have, the authors have not given any reason for not having included that. So we are still not very clear why that part was skipped. Another important thing that we found about this article is that study protocol was published. So I'm sure Dr. Rakesh would want to add in, but for trials that are more complex or trials that are multicentric or are done at a larger levels, there are many authors who would want to publish the protocol separately ahead before the study actually starts, so that there is critical evaluation of the study protocol, and if any changes need to be made at that level, they can be made before the study is started. And there was one change that was done in the study protocol that was published, was the addition of the lignocaine level, because the initial trial registration has no mention of measurement of lignocaine levels at 3 different time points, and that seems to be added at the level of the protocol. Any comments about publishing the study protocol, Dr. Rakesh?
So I think this is important, and we have brought this change into Indian Journal of Anesthesia. So you will see a multicentric trial protocol in next September issue, October issue. So we have started doing it because this is required when somebody do a multicentric trial. This is 2 regions. One, Madam Naik has already mentioned that people should scrutinize those trials protocols also, and they can put their input. This is one. Second, for the purpose of publication, because somebody is doing a multicentric studies, and there is some limitation of the limit of the word limits, and we expect that the methodology should be such that it is replicable, because as an author we are doing critical appraisal. If something is missing in those 2500 or 3000 words, which most journals allows for an original article, many of the information will be skipped. So that's why basically it will be a series of publications starting from protocol to full publication, so that authors have full information. So this is a well accepted norms, and IG has also started doing so now.
Dr. Vibha, can I just add?
Yeah,
Dr.
please.
Rakesh, what do you say about this sample size calculation, sir? Do you think in the pilot study they have used a sample size of 38 in each group? Isn't that adequate for a randomized controlled trial? what do you think? Why is it that they needed to again go back for 130 in each group? Don't you think that 38 in the initial study itself was an adequate sample size? And if we had to see any effect, we would have seen with those numbers, and just increasing the sample size, it didn't seem to make
So,
much.
so when we do a long studies and when something is being very novel and we do a pilot study, actually the concept of pilot study for sample size calculation is not at all good. And this will not give you anything. If the pilot study data is acceptable to us, why do we want to do a full study? Why don't we publish a pilot study and says this is better than that? So the sample size calculation from so-called 10 cases, 20 cases as pilot and then doing a full study is not a good idea. So this needs to be done. It will be a feasibility study, full feasibility study, or sometimes an exploratory study to look for the various variables when something is being started afresh. But since Lignocaine infusion is being done for very long, it's nothing new. It has been done in various other surgeries. It becomes new for other surgical procedures. So there are two ways of doing a sample size calculation. If you think that the surgery being done from which the sample size is being extrapolated, in that situation, you may accept the same sample size on those. But if you think, say, for example, if I put it CA breast versus CA lung, absolutely different. Or hepatic surgeries versus thoracotomies, absolutely different requirement. So you cannot compare those things. And sometimes there is another tool which people have started using it. They will start doing the studies, they will do a block randomization, and they will do an interim sample size calculation, because now we are not breaching the randomization here. So if I know that there are 100 patients, say 52 in one, 48 in other, I know this is the sample size calculation, and for this reason 100 patients were there, and I start a study of 100 randomized patients. If I intervene in between, I have to breach the randomization code, which is not acceptable. So many of the studies, which are bigger studies, they do a block randomization, a series of randomization, and they have to disclose a priori that at this step, if suppose, for example, there are 6 blocks, 6 patients in each block, and they start doing it, they say after 5 blocks, they will assess for the suitability. After 10 blocks, they will allow the suitability and then look for the sample size calculation and maybe the futility of continuing the studies. So this is the other way of doing a sample size calculation, but whatever is being done has to be disclosed. That's the only thing. If they can justify that why they have increased sample size from small to bigger one, fine, because there is justification for it. But remember, all RCTs works on the basic principle of assumptions for statistical analysis. And one of the assumption is randomization and allocation concealment. So if you breach that assumption, the statistical tool that we apply for comparing two groups in the RCTs, that assumption is wrong. If that assumption is not followed, then this means we cannot apply the statistical tool for RCTs. If we cannot apply, we don't have any p-value or 95% CI. So everything is out of the way. Then it just becomes a descriptive exploratory study rather than an RCT. So I think this is, I think I'm clear to a certain extent, ma'am.
Yeah, thank you.
Sure. I think a lot has been said about the methodology by Dr. Taseen as well as Dr. Indira. What I would do differently if I were to do this study, first thing is I would exclude patients where I feel that a significant amount of liver is going to be removed. So maybe when the FLR is going to be less than 40%, they should have explicitly put these patients as in the exclusion criteria. And like Dr. Indira said, that even after recruiting them, if the patient is on significant vasopressor support or there has been significant blood loss, that should have been an additional exclusion criteria. Another important thing I feel is that they have excluded patients with chronic opioid use, and typically we would describe it as any patient who's taking opioids for more than 90 days. However, studies have shown that even if preoperative opioid has been used for 1 or 2 weeks, it can actually affect the postoperative opioid requirement. So rather than excluding only those who are chronic opioid users, they should have documented all the patients who have used opioids preoperatively, and they could have compared the two groups as a baseline characteristic parameter for this. I also have a big objection over the drug mixture, but I think Dr. Taseen has already mentioned that it would have been better if lignocaine alone would have been used as an infusion so that it was better possible to assess its efficacy. Yeah, I think that's all from me so far. Let's move on, Dr. Taseen.
Results. This is a consort flow where they have actually assessed 1,088 patients, and they have excluded 828 patients, among whom 760 patients did not meet inclusion criteria. So finally, they have randomized 260 patients, where 130 patients were included in the each group. The demographic data they have given with the baseline characteristics in both the groups were age, sex, BMI, and ASA physical status, medical history, history of abdominal surgeries, preoperative liver function, and the maximum tumor size. And they have used absolute standardized difference for comparing the demographic data in both the groups. Intraoperative data, they've included both the open and laparoscopic surgeries. Open surgeries according to 100 in each group nearly, and laparoscopic surgery 30 in each group. The rest of the parameters such as duration of surgery, hepatic inflow occlusion time, duration of anesthesia, intraoperative morphine equivalent consumption, colloid crystalloids, and blood transfusions were comparable by using absolute standardized difference. Primary outcome, in the first figure, they have given the incidence of moderate to severe pain with the movement evoked pain, especially that is significant in both the groups at the time interval of 24 and 48 hours, but it is not significant at 72 hours. Whereas the incidence of the moderate to severe pain at rest, this is not significant in both the groups and it is comparable. In the second figure, they have shown the NRS pain scores with the movement evoked pain, which is significant at 24 and 48 hours. That is more in the placebo group, whereas the NRS pain score at rest, it was significant only at 24 hours in the placebo group. Secondary outcome. The secondary outcome mainly is talking about the opioid consumption in morphine equivalents, which is significant at 24 hours and it is comparable in 48 and 72 hours. The other parameters used in the secondary outcome are time to recovery of bowel function, PONB, loss of length of hospital stay, patient satisfaction score were similar, but except postoperative pulmonary complications, which were less in the lidocaine group when compared to the placebo group. This is a scatter plot explaining the lidocaine concentration after a bolus infusion at the end of the surgery and at the postoperative 24 hours postoperatively. Only one patient at the end of the surgery has reached the toxic dose of 5.4 microgram per ml. Two subjects experienced minor adverse events, including drowsiness, metallic taste, which disappeared after suspending the lidocaine infusion. But when this event happened, exactly the time period was not mentioned. Critical appraisal results. Participants pro. For each group, the number of participants who were randomly assigned received intended treatment were analyzed for the primary outcome. Yes. For each group, losses exclusion after randomization together with reason nil, as they have used modified intention to treat approach. Recruitment, dates defining the periods of recruitment and follow-up, it is mentioned. Why the trial ended or stopped, it was completed and results were below minimal clinical important difference. Baseline data, a table showing baseline demographic clinical characteristic for each group. Yes, it is mentioned. Numbers analyzed, number of participants included in each analysis, whether the analysis was by original assigned groups. Yes. Outcomes and estimations for each primary and secondary outcome, results for each group and estimated effect size and its precision is given clearly. per binary outcome, presentation of both absolute and relative effect size is recommended. Relative effect size is not given. Ancillary to analysis, result of any other analysis performed, including subgroup analysis, adjusted analysis, distinguishing pre-specified from exploratory, no. Harms, all important harms are or unintended effects in each group. It was mentioned, however, lidocaine infusion at lidocaine concentration at 72 hours could be more appropriate. Critical appraisal. The results presented in tabular form, they are logical, comprehensible. The results are explained in both tables and text. They are rightly numbered and titled. Results are presented on the basis of their aims and objectives of the study. Two patients experience adverse event, but at what time period it happened and whether the liver dysfunction was evaluated, details are not available. There could be a huge difference in pain scores because they have included both open and the laparoscopic surgery, which was not robustly explained, and it could have affected the final outcome too. Lidocaine concentration at 72 hours was not analyzed, which can have a cumulative effect in the post-hepatectomy liver failure patients.
Sure. Thank you, Dr. Taseen. So overall, after looking at the amount of lignocaine that has gone in and in variable dosage, I personally feel that such a huge effort of even publishing the protocol earlier and then doing such a big study probably sounds futile because they have not been able to use adequate concentrations of lignocaine, and they have not found adequate effects, meaning the analgesia. However, we are still contemplating whether the lignocaine can add to analgesia in these patients. However, if an adequate dose is not used, looking for effects can be futile. So I think this is my most important statement or a take home from the entire study, actually. I was quite hopeful when I read the title and read the abstract, but after reading the study, I realized that probably a better methodology could have addressed some of these lacunae that are there in this study. Another thing that I feel is that the intraoperative morphine equivalents that have been used are in the range of 200s. Taseen, could you just go back to that slide? And that to me sounds kind of high. So I feel that for some reason, they have a very high usage of opioids intraoperatively. Postoperatively, what they actually found was the difference in the opioid usage in the two groups was extremely low. And I think that possibly was because they were not able to adequately achieve plasma concentration of lignocaine. So this is my take on the results section. Anything from you, Dr. Indira?
Yeah. So for us to say whether a treatment has analgesic has taken effect, it should actually reduce the NRS by 1, or if you're having a scale of 100 millimeters, it should reduce by 10 millimeters. And if you look at the NRS score, can you go back to the slide of NRS score, Dr. Taseen? You see that the NRS scores at 24 hours and 48 hours are in the range of 3 to 4. So in the study group, it was 3.7, and in the placebo group, it was 4.2. And on the second day, it was 3.8 and 3.3. So there is hardly a difference of 0.5. So in terms of pain, it is the incidence is definitely decreased, but the intensity of the pain, I do not think it has helped. And going to the morphine consumption, next slide, please. So even the morphine consumption, for it to be clinically relevant, it has to be at least 10 milligrams. And you see that the mean difference is 5 milligrams, and the confidence interval of this was 1 to 9.8. So even the other end of the confidence interval didn't reach the 10 ng. So as you have said, Dr. Vibha, looking at the effort is taken to do this study and looking at the results, maybe I might use Lignocaine, but with more emphasis on the safety aspect, because of not just analgesic effects, but also because of the anti-inflammatory properties. So we see a difference in the postoperative pulmonary complications. So is it because of good cough, because of good analgesia, or is it because there is some anti-inflammatory action of lignocaine per se, which has led to reduction in the postoperative pulmonary complications? So it would have been nice if they had the interleukins and the tumor necrosis factors, and if there was a difference, then we could have correlated it with the postoperative pulmonary complications. That's it.
Sure. Do we move on, Dr. Taseen? I also wanted to, because we are coming towards the end of the journal club, I wanted to ask the attendees that if they have any questions that need to be addressed, or if they have comments related to this article, please post it in the Q&A section and we would be able to take it up. I'm not very sure. I think someone has raised their hand, but I'm not very sure whether we'll be able to allow an access for you to speak. However, we'll definitely take up your comments and we will vocalize them. Dr. Taseen.
Yes, sir. Discussion. According to the previous studies, opioids which provide effective relief from pain, that is at rest, but they have relatively little effect on movement-evoked pain. Conversely, the results indicate that IV lidocaine was more effective in relieving movement-evoked pain at 24 and 42 hours, especially moderate kind of pain. Although they have observed that subjects with prolonged IV lidocaine treatment experience fewer post-operative pulmonary complications, possibly because of the movement-evoked pain, the relief of movement-evoked pain. Unexpectedly, prolonged IV lidocaine treatment relieved movement-evoked pain for 48 hours but not 72 hours post-operatively. This might have been because of their low infusion rates after surgery, which was 0.3 to 0.5 mg per kg per hour, which were less than the lowest recommended dose. Although IV lidocaine reduced postoperative opioid consumption, the difference was not great enough to reach minimal clinically important difference of 10 mg in IV morphine equivalents. Limitations. The plasma concentration of lidocaine in the study was lower than the recommended therapeutic range, which may contribute to the failure of to reach minimal clinical important difference per morphine consumption. Distinct effect of IV lidocaine on movement-evoked pain and pain at rest were not fully investigated in their study. So, therefore, the comprehensive research on this issue is warranted in the future. Critical appraisal. Limitations, trial limitations addressing source of potential bias, imprecision, and if relevant, multiplicity of analysis was given. Generalizability, combination of drugs used may not be available in many hospitals. Interpretation consistent with results balancing benefits and harms and considering other relevant evidence not consistent. Harms and post-hepatectomy liver failure patients were not monitored.
Yeah, did you want to finish this?
Yes, ma'am. Critical appraisal, discussion of the study is presented in a meaningful way. They have highlighted the important findings and explained the findings of the study. The study were compared with the existing literature logically and reasoned properly with the explanation. It has mentioned the limitations of the study and also highlights the future study and protocols. However, post-hepatectomy liver dysfunction were not checked as their drug metabolism is altered.
Dr. Indira? You need to unmute yourself.
I think the discussion, she's more or less covered most of the things, but I just wanted to add one particular study which has come in anesthesiology in Jan 2023. In this study, what they have done is that they have given infusion of lignocaine 1 milligram per kg, 1.5 milligram per kg bolus, and continued the 1.5 milligram per kg bolus infusion till the end of the surgery in patients who were undergoing donor hepatectomy in live-related liver transplantation. And they have found that the clearance of lignocaine is reduced from 0.55 liters per minute to 0.17 liters per minute. So there is significant reduction in the clearance, and they stopped the drug at the end of the surgery. And what I feel that we have to take from that particular study is that there is definite difference in the metabolism of liver. It is you need to monitor, especially if you're giving for 3 days in a case of hepatectomy. And so 24 hours is not an option monitoring for the levels. The study also said that we should look at the metabolites of lignocaine and add to the cumulative toxicity, and also not continue monitoring even after stopping the drug, because though half-life of lignocaine is 100 minutes, in the post-hepatectomy status, it can be prolonged. So not only the dose, but the duration of this thing will be prolonged. So in that particular study, they had a remnant level of 45%. So probably in the discussion of this particular study, since it came good 6 months before, it should have been included.
Sure. Thank you. Could we move on to conclusion, Dr. Taseen? We are already more than an hour and 10 minutes.
Conclusion. Prolonged intravenous lidocaine infusion by including lidocaine in a PCA pump reduced the incidence of moderate to severe movement-evoked pain for 48 hours after hepatectomy. It also reduced the incidence of postoperative pulmonary complications. However, the reduction in pain scores and opioid consumption was below minimal clinically important difference. Critical appraisal. The conclusion of the study is presented in a meaningful way following the results of the study. It presents the aims and objectives of the study, even though they found difference, but the difference is minimal clinical important difference, and this was explicitly explained. Does the study add anything new? Here we say the results of this study is minimal clinical important difference. So the doses used were below recommended range, leading to the failure, and also the combination of drugs used may not be available everywhere. So applicability of this research is doubtful. Hypothesis was to evaluate lidocaine infusion for 72 hours, but conclusion mentions about 48 hours. So it could have they could have mentioned about 72 hour assessment. Critical appraisal others. Registration number and the name of the trial registry, it is mentioned. Protocol where the full trial protocol can be accessed if available. Yes, in the clinical trial registry, and also protocol was published too. Funding. Source of funding and role of funders. Yes, it was funded by the academic grant.
Sure. So I think the authors have concluded appropriately when they say that though the incidence of moderate to severe movement evoked pain is lesser with the lignocaine infusion group, however, the amount of opioid usage is not significant. However, they mentioned that there is reduction in the pulmonary complications, but I would like to take that with a pinch of salt, because just having reduction in pulmonary complications without significantly reduced incidence of pain could also be coincidental. So I wouldn't really want to focus much on that part, though it has the anti-inflammatory component that Dr. Indira added. Probably we would need to have a study which looks at the post-operative pulmonary complications as the primary outcome, a study that is powered for that as an outcome, to be able to really say that IV lignocaine infusion can reduce pulmonary complications. as a take on the study, I still feel that lignocaine infusion probably is not yet well studied and explored for post-hepatectomy patients. This study, though, has used lignocaine infusion, has used it in combination of drugs which are not like sufentanil, which is not available to us. So the direct applicability of this study to our scenarios would be very, very limited. The dose they have used is less. However, they have also not monitored the lignocaine concentrations at 72 hours, which would probably be most important to measure. Measuring it at 24 hours is okay, but I think I would have really wanted to know the concentrations at 72 hours, because at that point of time, actually, lot of factors come into play, including not just the amount of liver that has been removed, but based on the hemodynamic condition and the liver function at that point of time, the metabolism of lignocaine is going to get affected. So I think the authors have tried testing this hypothesis, but the verdict is still not out so far, is my take on it. Dr. Indira, do you want to add anything for the conclusion? I see a couple of questions there, and once Dr. Indira summarizes, then I think we can take them.
Yes, so I would agree, Dr. Vibha, that I would like to use a continuous infusion of lignocaine alone and at a higher doses, at the same time have an eye on the adverse effects and monitor the levels for 72 hours, and probably look at the other good effects of lignocaine infusion too, like inflammatory markers, etc.
Sure. Dr. Rakesh, anything from you before we take up the comments?
No, absolutely. I think very nicely covered. All the important aspects has been covered. One question was, somebody was asking the statistical significance equivalence to clinical significance. So I think you can elaborate once more, because many of the times we say p-value is 0.001, this is better than that. But sometimes we find that it is just leading to a reduction of length of hospital stay for 5.2 days to 5 days. Or maybe a reduction in the VAS score from 3 to 2, though it's a 1 reduction, but 3 is acceptable for us. So in that sense, you can just clarify.
Yeah, absolutely. So I think the first thing I think I want to say on this is that what is clinically relevant has to be defined before, because it can vary with different situations. So that has to be defined. However, in this study, like Dr. Indira mentioned, that the clinically important difference in a pain score, if measured from, say, 0 to 10, would be a score of 1, and which is not achieved with this study. And also, clinically important difference in amount of morphine consumption should be 10 milligrams, so which also is not achieved in this study. So having a statistically significant difference in the incidence of moderate to severe pain, but not correlating to clinically important differences would probably have no meaning. So does that answer the question, Dr. Rakesh?
Yeah, absolutely. I think this is what we need to look for. And simultaneously, we need to remember, which Madam Naik was explaining, that if we assumed in the sample size calculation a difference of, say, morphine consumption on NRS score, and if in actual study that assumption difference is not seen, so this means the study remains underpowered. So it's not adequately sample size also. So we should be cautious, because that's why I mentioned in the beginning, when we say a pilot study, it will not give an actual value. And if we say that the morphine reduction or morphine requirement in the post-operative period or the peri-operative period was from, say, 20 milligram to 10 milligram, but actually in a study you find that it was 15 milligram to 13 milligram. So this means the study remains underpowered. So that also needs to be extrapolated when you're looking for the sample size. Just don't see that it was 100 patients and 100 patients done, but what assumption was made, whether that assumption was actually seen in the study, also needs to be seen in the critical appraisal.
Sure, thank you. I think another question, suggestion to share the article 7 days before. I think the article was shared 3 or 4 days prior. But yeah, I'm sorry. We'll make sure that the article is shared 7 days prior to the next journal club. Point well taken. Thank you.
I think SOAPC headquarter will take care. Dr. Anjali Pingle and me will take care about sharing the information on time from the various speakers who are coming here. So I think we have already crossed almost 20 minutes, and it was a very, very interesting discussion. Many key messages. In fact, I could learn so many new things from this discussion from 3 allied speakers and chairpersons on the screen. And this was really useful to me at least, and I'm sure it will be for others participants also. A good number of participants were there. I sincerely thank Dr. Taseen Mahvish for a wonderful session. It was a very clearly put critical appraisal. I would suggest Dr. Taseen, with the permission of Dr. Naik, if you can share your PPT in the same group, people will have an idea that how to do a critical appraisal at their centers, or when they do it, it will be good for many postgraduate students who are doing critical appraisal, because the slides were good. I also thanks Dr. Vibhavari Naik and Dr. Indira Gurajala, who has taken the discussion from beginning to end, giving us many insight into article. Sometimes we are into flow of seeing a good journal like BJA or anesthesia analgesia. But when we start reading those aspects, we Indians are the best. So we do a lot of good studies. So sometimes we should not be flow into a study and just read the conclusion and change the clinical practice. There are many things that needs to be looked into those articles. I remember my couple of days back when I became just a new faculty a couple of years back, and some of my residents will come, sir, this is a new case report. Can I get the case done? This appears to be quite interesting. So can I get that done? And we should change our practice. I was also enthusiastic and say, okay, this is good, so we should go about. But then a single case report or a single study may not be sufficient to look or change into a clinical practice. The other important aspect, I will just summarize it. When we say the evidence-based medicine, it's just not the research outcomes. It has 3 pillars, where we also include the patient values and the experience of the clinician as 2 pillars, in addition to the 3rd pillar of the evidence that we come up. At times, we say that the research outcome is that this intervention, Lignocaine infusion, is good. But if you think that our clinical experience, we have never used it, we are not sure about its toxicity profile, we are not sure that we don't have the institutional availability of plasma Lignocaine level for long-standing studies, and we cannot see it since some complication happens, probably that study is not suitable for us from our center, though it has been proven. So the evidence-based medicine should have all the 3 pillars when you change your clinical practice. So thank you once again, Dr. Vibhavari and Dr. Indira, along with Dr. Taseen, for interesting insight. I'm sure it will help us to, in fact, you have taken the journal club to the highest level, and it will be a good learning for all of us. Thank you so much.
Thank you,
Thank
sir.
you so much. Bye-bye. Good night, everyone.
Thank you, Vibha. Thank you, Taseen.
Thank you.
ma'am.
Thank you.
Thank you, sir.
Yeah, thank you, everyone. Thank you.
Over to Ms. Rupsa for the conclusion.
Thank you so much, sir. Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I'm signing off here. And good night.
Thank you, Dr. Rakesh, for wonderfully moderating it. Thank you.
Ma'am, I think you have done a great work, as usual.
Oh,
Thank you so much.
Yeah, bye-bye. Good night.